function in high acidic environments. That's why it works well in the mouth, where the pH is around 7.2. Stomach has a pH of 2 or 3. It won't function there. So we like to park the carbohydrates in the fundus region of the body, and then before it moves on into the fundus region of the stomach, before it moves into the body of the stomach and out through the pyloric sphincter at the other end. Now, here's our stomach right here. There is the esophagus coming in. This is where we have the cardiac sphincter located right at this region here. There's the duodenum, the small intestine, the first part of the small intestine. There is the cardiac sphincter. There is the pyloric sphincter. There's the fundus, the top curve here of the stomach. So what we're looking at, cardiac region there, body there, pylorus there. So let's take a look at the at this structure. So over here, we've got, here's our stomach. Okay, there we go. So here's the esophagus coming in. This is the cardiac sphincter here. The role of the cardiac sphincter is to control movement of food going into the stomach. It's also trying to keep stuff from coming back out. It's the failure of the cardiac sphincter that causes acid reflux. Here is the fundus over here, this top curve here. So when something that has amylase in it, for amylase to finish the job of digesting carbohydrates, it's going to do it up in here. This is the body of the stomach here. The cardiac region is this area here, located closest to the heart. Here is the pylorus here. This is the pyloric sphincter right here, which controls movement of digested material into the duodenum, the beginning of the small intestine right here. And so we have a sphincter at this end, and we have a sphincter up here at this end. You'll also notice all these ridges in here. These ridges are called rugae. The ridges give us increased surface area for absorption I don't want to say nutrients, but it gives us more surface area for the nutrients that are being digested to absorb the various stomach acids or chemicals to break them down. Because we don't really do any absorption in the stomach. The absorption's taking place all in the small intestine. So let's move out of this and go back to this. Okay, so there's our stomach. There's the lesser curvature of the stomach. And of course, if there's a lesser, we have to have a greater. There's the greater curvature. That's the outside curve and the inside curve. The stomach has been described as a J-shaped structure sitting on the left side of the abdominal cavity, right underneath the diaphragm, directly across from the liver and on top of the pancreas. And you can see the pancreas is sort of tucked away right in here. So now, longitudinal muscle, circular muscle, just like everywhere else in the digestive tract. But now we also have, excuse me, the oblique layer, because we want that stomach to churn in three different directions. And there's the oblique layer of smooth muscle. So we have 3 layers. Everywhere else in the digestive tract only has 2. And there's our stomach laying there. There's the esophagus, the duodenum, the cardiac sphincter, or if you want the other term, it's the gastroesophageal sphincter. Cardiac region right below the esophagus. The fundus is that curve up there where we go to put carbohydrates in. There's the body. There's the pyloric region. lesser curvature, greater curvature. Now, this is what the stomach looks like on the inside. These are the rugae. These infolds are the rugae, increasing the surface area so that everything that goes in the stomach can be exposed to the various chemicals in the stomach, including the acids. There's smooth muscle layer there, the circular muscle there. Here we have our connective tissue, the submucosal layer. Here we have the mucus layer. And these, as I said, these ridges are all the rugae that we encounter. Okay, that's a rugae right there. And again, the rugae is to increase the surface area so that we can churn and mix the ingredients in the stomach with the various chemicals that we're going to release. And there's the lumen of the stomach. So now here's what the rugae really look like on the right-hand side. Again, are all these ridges. The models are pretty good about that. You can see on the drawing there, the 3 layers of smooth muscle. You can see the rugae, you can see the pyloric sphincter and the location of the cardiac sphincter in here and the beginning of the duodenum. Again, these ridges really provide an increased surface area for us for exposing the material, the food that we've eaten, the food that's being processed, to continue the process of to continue digestion in here. Because here we're going to break down proteins, we're going to break them down to their amino acids, we're going to continue that process in the small intestine, we're going to finish breaking down carbohydrates, and we're going to be processing fats, but we're going to finish the processing of the fats in the small intestine. Okay. Again, there's the inside showing all the rugae. There's the cardiac sphincter. There's the pyloric sphincter. And again, the pyloric sphincter leads into the duodenum. Now, within the stomach, we have a series of pits, gastric pits, lining in the simple columnar epithelial cells. So the outer layer of the stomach is simple columnar. We've got 3 layers of muscle underneath that. These pits, these openings in the simple columnar cells, these gastric pits, lead into gastric glands embedded inside the tissues. And these gastric glands have a series of cells that are going to release different types of components. We've always heard that stomach acid is hydrochloric acid. That's only one of the substances that are secreted from these gastric glands. You know, this whole concept of gastric juice includes the acids, but other chemicals in here too. If you remember intrinsic factor and pernicious anemia, here's where we release intrinsic factor. So we have 5 types of cells in the gastric glands. We have the chief cells that are going to secrete pepsinogen. Just like everything else in our bodies, pepsinogen is the inactive form of pepsin. You know, just like fibrinogen is the inactive form of fibrin, and prothrombin is the inactive form of thrombin, we've got something known pepsinogen, which is the inactive form of pepsin. Now, pepsinogen will become pepsin when it's exposed to hydrochloric acid. So the chief cells secrete pepsinogen. The parietal cells within the glands secrete hydrochloric acid and intrinsic factor. We know we need intrinsic factor to absorb vitamin B12. But the parietal cells are going to secrete hydrochloric acid, which activates pepsinogen to become pepsin. Pepsin then allows us to break down proteins into the component amino acids. Goblet cells and mucus glands secrete mucus. We know that goblet cells secrete mucus. The mucus is alkaline. The mucus covers the lining of the stomach. The stomach is held together by cells that are with cells put together with tight junctions. But that's not enough. The tight junctions prevent any leakage from the stomach, but they're sensitive to the stomach acids. So we have to cover these cells with an alkaline mucus to protect them. And so we don't burn away the lining of our stomach with our own acids. So we have goblet cells and mucus glands secreting an alkaline mucus so that we don't damage the lining. They are held together with tight junctions, so there is no leakage, assuming the mucus is working. And then the last category of cells are the enteroendocrine cells, which produce gastrin. Gastrin then allows us to help. It helps, it's a hormone that helps in the process of digestion. And of course, I almost forgot the stem cells, because we've always got stem cells. Stem cells are going to become, like we have stem cells in the blood, stem cells in the ovaries and testes, the stem cells are going to become the other cells as needed. So the stem cells can differentiate into any of the other cells we need, chief or parietal or goblet or enteroendocrine. So we have 5 types of cells embedded here. Here's our pits right here. And within the pits, we have the mucus cells and the parietal cells and the gastric glands and the chief cells embedded in here. And they're going to release they're going to release mucus, they're going to release hydrochloric acid and intrinsic factor, they're going to release pepsinogen, they're going to release gastrin, or they're going to be stem cells. And so that's what their role is, to generate these juices, or as they call them, the gastric juices, so that we can finish breaking down proteins, finish breaking down fats, absorb vitamin B12, aid in the process of digestion, and then make more of them. So, okay, said this already. We've got 3 layers of smooth muscle instead of just 2. We churn the contents of the stomach better to expose all the contents to the various gastric juices that we're forming. So, and what we're going to end up with is a highly acidic, sort of goopy mixture. It sort of has condensed, it has the appearance of condensed soup. You open up a can of condensed cream of mushroom, dump it out, and it's sort of thick and sort of oozes around. That's what the appearance of the stomach contents are going to look like as it's ready to move into the small intestine. There's your gastric glands again, and your pits running down here. And here's where you're going to be secreting your hydrochloric acid and your pepsinogen and your intrinsic factor, all in these various pits along in here. There is very little absorption of food in the stomach. We will pick up water, we will pick up glucose, we'll pick up sodium, we'll absorb alcohol in the stomach, but not food. We're not ready to absorb the food yet. We still have mechanical and chemical digestion going on. We keep the pH around 2. The breakdown of the proteins starts when you form pepsin from pepsinogen. You need the hydrochloric acid that you've produced to convert pepsinogen to pepsin. Then we can start breaking down the proteins. Now, the substance that this whole goopy mixture that we produce is called chyme. It's very thick. But it's very acidic. It is the broken down food mixed with all the gastric juices, and it's going to be essentially pushed through the pyloric sphincter into the small intestine. We still have to finish the breakdown of the proteins, and we still have to finish the breakdown and absorption of the fats. But we don't absorb food in our small intestine. So, Problems, ulcers, gastric ulcers. A gastric ulcer occurs as an infection of the lining of the stomach. It's caused by a bacteria known as Helicobacter pylori. We damage the ability of, for whatever reason, we've damaged the ability of the stomach lining to make mucus. The alkaline mucus protects us from the stomach acids. And if we expose that lining to those acids, it's going to dissolve away the tissue. It's going to cause a lesion. As you see here in the illustration, this is an ulcer or a lesion that's formed. People that take NSAIDs, anti-inflammatory drugs like aspirin or ibuprofen, will often, if you continue to take them for long periods of time, they irritate the lining of our stomach to the point that they destroy the ability to break down, to make alkaline mucus, and we can develop an inflammation. The inflammation was always thought to be caused by stress. Well, stress may play a role in it, but the actual ulcer is usually caused by Helicobacter pylori and can be treated with antibiotics and cured in 2 weeks. Now, but you can also damage the lining of your stomach by taking mega doses of aspirin or ibuprofen. Many people believe, we'll take 800 milligrams of ibuprofen routinely, simply because they hurt, or they'll take aspirin. It's also an anti-inflammatory, and these anti-inflammatories will irritate the lining and leading to these gastric ulcers. Ulcers can form anywhere in the stomach. We see them located up here in the fundus, in the body, all the way down here to duodenum. Again, what happens is that we've removed the mucus protective layer, and now the stomach acids, the gastric juices, are eating into the mucus layer, causing a great deal of pain. And if they go in deep enough, they'll cause bleeding. And that becomes a very serious condition when your patient has a bleeding ulcer. Okay. Something else that happens. There is also a condition known as a hiatal hernia. A hiatal hernia occurs when there's a tear in the diaphragm. Straining to defecate, straining, picking up something heavy. For a variety of causes here, there is usually a tear in the diaphragm, and part of the stomach can push up into above the diaphragm itself. As we see here, here's a normal esophagus. There's the opening for the esophagus and the diaphragm. We have a tear in the diaphragm itself, and part of the stomach protrudes through. And it's not unusual. Many people have hiatal hernias and aren't aware of it. Say at some point, maybe 80% of the population have hiatal hernias. Now, the problem, though, is that this is a very common cause of gastroesophageal reflux disease, what we call GERD, what we used to call heartburn. I guess we still call it heartburn, or acid reflux here. By pushing part of the stomach up above the diaphragm, now we start seeing movement of stomach acids, gastric juices, up into the esophagus and burning the lining of the esophagus. The esophagus is not protected from gastric juices like the stomach is. And so we see this frequently occurring in people. And as I said, this is probably one of the most common causes of acid reflux. So the hiatal hernia, again, caused by, increasing the inner abdominal pressure for some reason, whether sometimes it can tear through a sneeze, a cough, picking up something very heavy, straining to empty your bowels. Lots of things can cause this. Like I said, up to 80% of the population in the United States may have had a hiatal hernia at one time or another. So I just said all that. Heavy lifting, good way to get one. Hard coughing, hard sneezing, violent vomiting, and straining during defecation, the Valsalva maneuver, creating pressure on your diaphragm. Because when you are straining during defecation, you're holding your breath, you're putting pressure on the diaphragm. Individuals who are most at risk are individuals that are obese and older individuals. For whatever reason, older individuals seem to have more issues with defecation than younger people do. But obesity seems to be the biggest issue here. Since we have an epidemic of obesity in the United States, we see this reflux issues more and more. So, acid reflux is a major health concern. It's not an epidemic, but it's a concern. Lots of people have acid reflux because the stomach acids are moving up into the esophagus and burning the esophagus. And while it doesn't seem to be a major health issue, it can be, because constant irritation of the lining of the esophagus can lead to esophageal cancer. It is a gastroesophageal reflux disease once it occurs, is a lifelong condition. It is a chronic condition. Now, it can be treated very easily. There are numerous medications that will help this. Most of them work as proton inhibitors. They reduce the number of acid-producing cells or inhibit the acid-producing cells in the gastric pits, so you're not producing as much acid as you were before, and most of your reflux medications work on that principle. But it's a constant thing. If it's left untreated, it can lead to esophageal cancer. So what's it look like? Well, here we see a healthy esophagus over here on the right at top, and here's one that's been burned by acids, simply because the reflux, the movement of the stomach acids and the juices up into the esophagus are going to burn the lining. Okay. On that bright note, we'll move on and talk about the small intestine. The small intestine is 20 feet long. It has three regions. It has a duodenum, it has the jejunum, and it has the ileum. First region, the duodenum is where we complete the process of digestion and start absorb. Also, it's where we absorb most of our fat. So here's our small intestine right here, 20 feet long, about big around as your finger. There's the jejunum, mesentery holding it together. We look in the backside here, we can posterior view. There is the duodenum. The duodenum is only about 12 inches long, and then the jejunum and the ileum are the remainder. There's the ileum there. The ileum terminates in the ileocecal valve, which is a structure right here, where it connects to the large intestine. Right there's the ileocecal valve. And you can see the mesentery structures here holding it together. Okay. Cross section of our small intestine. Of course, we have the serous membrane on the outside, covered by two layers of smooth muscle, longitudinal and circular. There's our serous membrane there. There is our muscle layer right there. There's the longitudinal layer on the outside and the circular layer on the inside. And we move into the connective tissue submucosa. We move into the mucosal layer, and these are all simple columnar cells with many, many goblet cells, all these little dark spots here, the light purple dark spots where the arrow is, those are all goblet cells. So lots and lots of goblet cells. These are all simple columnar cells here lining the lumen of the small intestine, which is the lumen right there. Now, in the small intestine, we are going to break down the chyme as it comes in. Now, this is a very acidic mixture, and we produce an alkaline mucus to neutralize the chyme as it enters the duodenum. Our pancreas does that for us. Generally, about 6 hours after we eat, food is moving through the pyloric sphincter into the duodenum, and there it's going to be exposed to pancreatic enzymes from the pancreas, as well as bile from the gallbladder. Now, the liver makes the bile. The gallbladder is just a storage facility. We can very easily do without our gallbladder, but we still, we use it to store the bile that we're going to release into the duodenum to break down fats. Now, the duodenum, the jejunum, and the ileum. The ileum is going to connect to the large intestine. Most of our absorption takes place in the simple columnar cells found in the jejunum. However, we do absorb iron in the duodenum and B12 and bile salts in the ileum. We take in water and fats throughout. And we're also going to recover glucose and sodium bicarbonate. So the first part of the small intestine is the duodenum, and we can see the duodenum here on this model. Let me get this off here. Okay, here is our duodenum right here. And this is the pyloric sphincter right here. And we have this 10-inch section here called the duodenum. You'll also see the pancreas along in here. And this white structure is the pancreatic duct that dumps directly into the duodenum. The pancreatic duct is going to release pancreatic enzymes to break down proteins. It's also going to be producing an alkaline mixture to neutralize the acidic chyme. Over here, we see the gallbladder, and we see the bile duct leading down into here. And the bile duct and the pancreatic duct will come together into one structure and release bile. Now, the role of bile is to chop up and break down fats. So, because fats are large molecules, and they're not going to go across the membranes of the simple columnar cells easily. But if we chop them up into little pieces, and that's what the bile does, then we can absorb them in the rest of the small intestine. Proteins we're going to break down to their amino acids. And so the pancreatic enzymes here are going to break up the proteins, and the bile is going to break up the fat. Here we go. Okay, so the common bile duct and the pancreatic duct, that long white tube, come together in the duodenum to form what's known as the hepatopancreatic ampulla. The bile duct and the pancreatic duct come together. I'll just leave it like that. The pancreatic juices and the bile are controlled by, and this is another good word, the hepatopancreatic sphincter to release the mixture of bile and pancreatic juices into the duodenum. So, and here we see, there's our duodenum. Here is the pyloric sphincter right here. There is our pancreatic duct there. And there's just that little green thing is the hint of the bile duct. And they come together to have one structure, one duct releasing into the duodenum. Now, to increase the surface area of the small intestine here, we have ridges that form. These ridges are called the plicae circularis, and these are folds inside here. So we can increase the surface area, not just a simple open tube, but we have these infolds that increase the total surface area of the overall small intestine from, maybe the size of the floor space of this classroom, maybe 2 classrooms. It's a huge amount of surface area now by having these folds. It also tells you that you're in the small intestine when you see these plicae structures too. Okay, and there is the entrance to the jejunum right there. Now, as I said, so the plicae circularis, the circularies are the infolds that form. Now, these infolds contain structures known as villi. Villi is Latin for fingers, and these villi project out from the plicae. Coming off of the plicae, we have microvilli. So we increase the surface area even more. So easily, much more than the floor space of this classroom, maybe 2 classrooms. We have a tremendous amount of surface area for absorption now in the small intestine. And it looks something like this. Here we have a plicae circularis here, and you can see then here are the villi, the little fingers sticking off of here, and then the microvilli, you can't even see in the drawing, are coming off of that. Now, picture on the left is the small intestine showing the plicaes, the ridges, and then you can't see the villi or the microvilli on the picture, but they're there. Because if we were to look at them in a under the microscope, we could see them. There's another reason for these plicaes. The plicaes are sort of like if you consider a vacuum cleaner hose, and they have those ridges through the vacuum cleaner hose. I use this analogy for the trachea all the time, but also the vacuum cleaner hose has like a spring inside of it. And so that trash you're vacuuming up is sort of carried up in a circular pattern. Well, that circular pattern repeats itself with the plicae so that the mucus, the chyme that's coming through, can sort of rotate as it goes down and be exposed to all the chemicals that are coming in from the pancreas and the gallbladder. So here are your villi right here. The little finger folds sticking out off of the plicae, and then these little tiny structures here are the microvilli that you see here. Now, also remember that these are simple columnar cells lining the small intestine. Underneath the simple columnar cells are going to be fenestrated capillaries. And they're going to have lots of perforations in there for movement of nutrients to be absorbed. But also with these capillaries, you're going to have something else. The green structures there are called lacteals. They're part of the lymphatic system, the parallel circulatory system. The lacteals run up in each of the villi, running next to the capillaries. They are a lymphatic capillary, and they're going to absorb the fats, the lipids. So we have absorption of proteins and carbohydrates with the fenestrated capillaries behind the simple columnar cells, and we're going to absorb the lipids with the lacteals. Now, the lacteals are going to put those lipids into the lymphatic fluid. And the lymphatic fluid ultimately ends up back in the plasma, because lymphatic fluid goes through the lymph nodes and it goes through a duct and is dumped back into the plasma. So those fats, those lipids ultimately end up in the plasma where we want them. So pancreas is both endocrine and exocrine. We know its endocrine role. It releases glucose and glucagon from the islets of Langerhans. Alpha cells make glucagon, beta cells make insulin. We use negative feedback, but its exocrine function is to produce digestive enzymes and to neutralize the acidic chyme. The cells of the pancreatic duct, the cells that line the pancreatic duct, make the alkaline solution that's going to neutralize it. The acini cells, the cells that surround the islets of Langerhans, not the islets of Langerhans themselves, but all the cells around the islets of Langerhans, are going to make the pancreatic enzymes. So we're going to break down, any carbohydrate that got through, we're going to finish breaking it down here with amylase. We're going to break up fats. We're going to help the bile break up fats. We're going to break up nucleic acids. We're going to break up proteins. So, and again, there's the spleen just for reference. There's the pancreas, the duodenum, the tail of the pancreas for what it's worth, the body of the pancreas because we couldn't think of another name, and there's the head of the pancreas. There's the main pancreatic duct and the accessory pancreatic duct. And here are the acini cells. The islets of Langerhans is this light pink area in here where we're going to make glucagon and insulin, but the acini cells produce the pancreatic juices instead, the digestive enzymes, about 1.5 liters a day of pancreatic enzymes. And that leads us into the large intestine. The large intestine is only about 5 feet long. But we call it the large intestine simply because it's larger in diameter. It is controlled, access to it is through the ileocecal valve from the ileum into the cecum. The cecum is a pouch at the bottom of the ascending colon, the ascending large intestine. Okay, now let's go around like this. The ileocecal valve is this structure right here. This is the ileum, the last portion of the small intestine. The ileocecal valve controls access right here into the cecum. This is the pouch. This is the ascending colon right here on this side. And it then is followed by the transverse colon that goes across this way and the descending colon on the other side. Now, let's see, there we go. See a little better now. Okay. So here's the ileocecal valve right here. And going into the cecum of the pouch. This little structure down here is the appendix, right along in here. Let's go back to screen sharing. And oh, sorry, wrong set of slides. Here we go. Large intestine. Ileocecal valve is where the ileum and the large intestine come together. The cecum is this pouch. Anything that has not been digested is going to go into the large intestine. It's going to first go into this pouch. And then below this pouch is the appendix. Now, the appendix is not a vestigial organ. It is not a useless organ. It has a very important role to play as part of our immune system. Now, so large intestine, we have the cecum, the appendix, the colon, which has 3 parts to it, the rectum, and the anal canal. And so the cecum, the first part, is this area directly below the ileocecal valve. Everything that's indigestible has come in through the ileocecal valve and drops into this pouch. So now the appendix has a couple different different roles here. It may act like the tonsils. The tonsils are designed to be sacrificial in nature, to let themselves become infected to trigger our immune response. The appendix may have that same type of role. It also is designed to protect our own natural bacteria. Because the appendix, when the contents of the appendix, the undigested material that's found in the appendix also includes our own representative indigenous bacteria, the good bacteria. When our large intestine has been impacted by something that kills that bacteria, perhaps when your patient has a severe illness like dysentery or cholera, or has some sort of other gastrointestinal disorder which causes a lot of vomiting and diarrhea, and all the bacteria is gone, then the appendix can repopulate the bacteria with its own indigenous bacteria, which is really yours. It is your bacteria, the good bacteria, and allows it to fill in the spaces there. Otherwise, if we don't keep the good bacteria present, then pathogenic bacteria could move in. So we see the appendix has a role there to protect us in that sense. It also has to work with B cells and T cells, and we'll talk a lot about those in lecture, but that's part of our overall immune system, a response there. So the appendix is likely going to be a trigger for infection, because the appendix can become infected. Now, does every infection end up in the removal of the appendix? Many times, no. Many times it can be treated with antibiotics. Only if it's become inflamed and enlarged and ready to burst would we have to consider removing it. Okay. So here are the structures of the large intestine. There's the appendix right there, attached with mesentery to the ileum. There's the ileocecal valve right there. There's the cecum. This is the ascending colon. This is the transverse colon going across here, the descending colon on the other side, but we have what we call the sigmoid colon leading into the rectum, the anal canal, and the sphincter right here. We also see, instead of 2 or 3 layers of smooth muscle, we simply have a band of smooth muscle that goes across this little light gray area here. Oops, let me go back. This is all that's left of the muscle layer here. And we call this a tinea coli. So we don't have that double layer of smooth muscle like we had before. So we also see various pouches form in here. These pouches here are called hostrum. Talk more about those in a minute. So, okay, large intestine. Anything that's not digestible goes into the large intestine through the ileocecal valve. We want to have one more shot at taking water out of the residue and letting the bacteria that's present in our colon produce vitamin K and some B vitamins, and then we want to get rid of the fecal matter. So we recover water, we recover sodium and potassium here, we generate vitamin K. This is where our body makes vitamin K, which we need for clotting. So we produce that in the colon. and we recover as much water and electrolytes as we can. If we don't recover enough water, then we have essentially the recipe for diarrhea is watery stool, watery fecal matter. If we don't recover enough water, then the fecal matter is too watery and your patient has diarrhea. If we recover too much water, then the feces become drier and your patient is constipated. One of the consequences of taking pain medication, particularly the anti-inflammatories, is that anti-inflammatory drugs and pain medication often reduce the ability of the small intestine of the bacteria to recover water from the indigestible material, or allow us to recover too much water. So that's what happens, had it backwards there. Pain medication, particularly medication based on opioids, morphine-based pain medications, allow us to recover extra water. That extra water dries and makes the feces drier. It induces constipation. Even the regular NSAIDs like ibuprofen and aspirin do that too. Anti-inflammatories are going to reduce swelling. The swelling is caused by more fluid movement. So if we reduce that, we don't just reduce swelling at the location where we hurt. If we have a pain in the back and we take Advil or aspirin, an anti-inflammatory, inflammation is caused by the inflammatory response increases blood flow to a specific region, increasing water movement to bring in more plasma, bring in more red cells, bring in more white cells, take away debris and make things feel better. But it happens, it's a systemic response. It isn't just localized. So we pull water back from lots of areas. Person that takes a lot of anti-inflammatories or significant morphine-based pain medications can become constipated. Okay. The large intestine has three parts to it: the ascending, transverse, and excuse me, descending. Surrounds the small intestine on three sides here. It's only about 5 feet long, but its diameter is much, much bigger than the small intestine. We have one layer of smooth muscle called the Tinea coli. Those sacs are called haustra. The wall of the small intestine puckers into these sacs. And we have fat that hangs down from the small intestine also. Now, go on to the next slide. So here is our large intestine. There's the Tinea coli. There's the muscle layer there. Here are the haustra, the pouches, if you will. We see the fat hanging on in different locations. We don't know why they're there, but they're there. And those sacs often are the site of a condition known as diverticulitis. Diverticulitis is an inflammation of these haustra where we've trapped small food particles like seeds or nuts in there. And some people that have a very powerful reaction to that, irritates the lining of the haustra and develops a bacterial infection, causing a great deal of pain, fever, nausea, vomiting, stuff like that. Okay. So we have lots of simple columnar cells in the large intestine, and we have lots of goblet cells. We want to have movement through the large intestine very easily. And this is what the mucosal layer looks like. Simple columnar cells and many, many goblet cells. All these little white cells here are goblet cells. And you can see that these are all simple columnar, again, through here. Down here is our the Tinea coli layer down here. Okay. So what do we do in the large intestine? Well, we still have digestion taking place. We have mechanical and chemical digestion. The kind that has come through the small intestine to the ileocecal valve, the stuff that we can't process, the stuff that's high in fiber, the indigestible material, is going to come through the ileocecal valve into the cecum and into the large intestine. Then we're going to undergo chemical digestion with the bacteria to get the vitamins that we want to make. We want to make vitamin K, vitamin B, some of the vitamin Bs, and that's going to be the last of the chemical digestion. So, and again, the B complex vitamins and vitamin K are what we're going to synthesize here. The carbohydrates that we can't break down, like the cellulose, for example, the fibers, we're going to break them down with the bacteria. That breakdown of the bacteria through the process of fermentation releases acids and gases. That's where a lot of the gases that occur from eating foods that are high in fibers, like beans, for example. We all know what beans do to you. Well, it's because of the high fiber content of the beans and the carbohydrates. Well, the high fiber they are carbohydrates. The fiber is cellulose. And so when we process that, we don't get it, we can't really use those nutrients. So they undergo fermentation and they release the methane gases that give us difficulty. So, okay, the cecum, the colon, the rectum, and the anal canal. The cecum absorbs water and salts. It mixes the chyme with mucus and pushes, we start contraction from the Tinea coli, pushing material up the ascending colon into the transverse colon and down the other side. So we have ascending, transverse, and descending. We have the sigmoid colon, which connects the descending to the rectum, and then the rectum to the anal canal. There's our large intestine. There's the ileocecal valve. There is the cecum. There's the appendix. Doesn't quite look like that. There's the ascending colon. The hepatic picture near the liver. There is the transverse colon. There's the Tinea coli. The splenic picture near the spleen. The descending colon. One of the Hostrata pouches that form there. Sigmoid colon, the rectum, and the anus. Now, what do these things look like on the inside? Well, first of all, here is the ascending colon. You will never see it this clean, naturally. You would only see it this clean if your patient's having a colonoscopy and they followed the prep. If they didn't follow the prep right, then there's going to be fecal matter all over the inside of these in a colonoscopy. Ascending colon, nice and clean. Transverse colon is very, very distinctive by its triangular shape. Yes, it has ridges inside there. Do not confuse those ridges with the duodenum and the plicae circularis, because the duodenum doesn't have a triangular shape. The transverse colon has a very distinctive shape here. But again, these ridges are designed to sort of spiral the contents through, exposing the surface area to more bacteria. The descending colon at the end, again, has that same spiral shape. It has these rings there designed to increase the surface area. The rings, though, are not as close together as we see in the duodenum. And so try not to get those confused when you look at that. Again, you'll never see it this clean unless your patients get prepping for a colonoscopy. Okay, there's the sigmoid colon, which sort of looks like nothing, but that is the juncture between the descending colon and the rectum. The rectum penetrate, and we have the rectum penetrating the pelvic floor, leading to the anus, and we have sphincters that surround the anal canal that are both involuntary and voluntary. We can hold it for a while voluntarily through skeletal muscle. We can hold that sphincter, the external sphincter. The internal sphincter will often let go much earlier because it's smooth muscle, but our skeletal muscle, external sphincter, we can hold indefinitely to a point. So, and of course, here is our anal canal. There's the rectum up here. Here's the external sphincter on the outside. This is the internal sphincter here. This will often let go much earlier than the external sphincter does. So, but we do have the ability to control defecation. There's our rectum. Now, the process of defecation occurs as a spinal reflex. When the rectum fills up with fecal matter, movement of the large intestine, the contraction of the tinea coli will allow fecal matter to move from the descending colon into the sigmoid, into the rectum. The rectum will stretch. That will trigger a spinal reflex for defecation. It is part of the parasympathetic nervous system. Remember, parasympathetic is rest, digest, and defecate. Well, that's what we do. The sigmoid colon and the rectum are going to relax. The smooth muscle relaxes. The internal sphincter relaxes. And then when we're ready, we relax the external sphincter. But it is a parasympathetic response caused by the stretching of the rectum itself. Now, here we see a blockage in the ascending colon. Remember, soft tissue doesn't show up well under X-ray. Bony tissue does. But here we see this dark area is obstruction in the ascending colon. So we can see that the descending colon looks fairly clean. The transverse colon, which sort of goes up at an angle, which is perfectly normal, looks fairly clean too. There's only scattered amounts of material in there, but there's a large blockage right in here, and which eventually was cleared out. But you can tell that you'll notice that there's very little material at all in the sigmoid colon would be down here. It's empty. The rectum is mostly empty too. There's lots of material scattered throughout here in the transverse and descending, but there's some sort of blockage in here. Now, our colon will often grow polyps. Polyps are just connective tissue. It's perfectly normal. A polyp takes a long, long time to grow. It takes about 10 years to grow about a centimeter. They're not cancerous, but they have the potential to become cancerous. So when people have a colonoscopy, they usually have these polyps removed. So they just to eliminate the possibility. Like if you have a mole or something on your skin and have it removed, or have a precancerous lesion on your skin, having it removed. This is a colonoscopy. You want to get old people excited and talking about something, get them all talking about a colonoscopy. Elderly people love to talk about their last colonoscopy and how wonderful it was. I think they just enjoy the Propanol, the anesthetic.
And the propofol?
Yeah, the Michael Jackson drug. My mother-in-law says it's the best sleep she ever gets when she gets one. So anyway, but you take about a 5 or 6 foot long tube, that you run it up through the anus and into the descending colon and into the ascending transverse colon and down the other side, usually to the ileocecal valve. and you examine the insides, and it should be done every 5 to 10 years, looking for something growing there. Now, a lot of people are switching over to Cologuard, which is a chemical, essentially colonoscopy. You send it, you take a sample of fecal matter and ship it off to this laboratory in Minnesota, and they examine it for all the DNA and amino acids that might be present, that would be present if a cancerous material substance was growing there. A lot less invasive, you know. So it's all about you know, preference, I guess. So colon cancer, an uncontrolled growth in the large intestine. Now, the bad news is it's colon cancer. The good news is that colon cancers are very, very, very slow growers, usually. However, when they metastasize, the first place they usually go to is the liver, and that's never good. So we generally encourage individuals to have their colonoscopies done every 5 to 10 years. Okay. This is a colonoscopy. This is what it looks like going in. Usually takes about 20 minutes or so. Here we can see that we're in the transverse colon. Right there, you can just sort of see the triangular shape. And it whoever, you know, the prep was done very well for this because it's all nice and clean, and your gastroenterologist can see what's going on. Now, our liver has a role to play here too. Besides detoxifying all the foods and liquids that we eat and drink, it also produces bile. Without bile, we can't chop up fat. Now, a patient that has their gallbladder removed can still eat fat. In fact, they need to, but they're just not going to store any fat, any bile, because they don't have a gallbladder. So there's your liver. There's the gallbladder. Remember, the liver produces the bile that gets stored in the gallbladder. So emulsifying the fat is the role of the bile. That's the number one thing that the bile does for us. The liver also makes heparin and albumin and fibrinogen. Fibrinogen is a precursor of fibrin. The liver detoxifies our food. It stores glycogen, and as well as various vitamins, and activates vitamin D for us too. So, however, the liver can become cancerous. The liver, well, just to give you a sense of perspective, that's an individual's hand on the left-hand side holding onto the liver. That liver is full of tumors, and it's about 4 times its normal size. Liver cancer is usually always a secondary lesion, usually often coming from exposure from a cancer growing in the colon. So bile made in the liver, stored in the gallbladder. It is made from the breakdown products of hemoglobin. It emulsifies the fat and chops up the fat into small pieces. And without that, the fat particles would be too big to be absorbed. So the gallbladder sits underneath our liver, right about here on the right-hand side, about the size of a kiwi. It will produce, it will store bile. Now, what is the key to triggering the release of bile? When chyme enters the duodenum, there are enteroendocrine cells that will secrete a protein known as cholecystokinin. Cholecystokinin tells the gallbladder to contract and relax the sphincter that controls the bile. Cholecystokinin also tells the pancreas to release the pancreatic enzymes. So it is the presence of the chyme coming into the duodenum that causes the release of the cholecystokinin. Here's our gallbladder right there. And there's our duodenum. And when we get chyme going into the duodenum from the stomach, then that triggers the release of the cholecystokinin. So, problems with the gallbladder, gallstones. An individual who maintains a high-fat diet produces lots of bile. Now, if that bile, if they overproduce bile, that bile can crystallize and form salts inside the gallbladder. And if you look at the gallbladder on the left, it's been removed. Look at all the stones in there, and they'll block the bile duct and cause an infection, which produces, which is very painful. It causes nausea, vomiting, fever, flatulence, and a lot of pain with a gallbladder attack. Generally, the gallbladder is just begging to be removed at that point because those stones aren't going to go away on their own. Over here, we see the gallbladder intact, and we see the stones there that are present. Now, acute and chronic cholecystitis is the inflammation of the gallbladder. Patients that have gallstones will likely have cholecystitis. Antibiotics can be used to reduce the infection and eliminate the infection caused by the stones, but it is nearly always going to require surgery to get the gallbladder out. Now, the surgical procedure is very quick. 45 minutes, maybe. When my wife had hers out, it seemed like she was hardly in and back into recovery because it was a very quick in and out procedure. They do it laparoscopically. But again, chronic cholecystitis, is a little different from acute. Chronic gives you a lot more pain, a lot more gas. So, and triggers are often an individual that has gallbladder issues should try to avoid eating fatty foods like chocolate or cheese or any kind of pastry. And that is the end of the digestive system. So we can stop right here because this is the beginning of the immune system. So we'll just stop there. And that is the end of AP2 lab.